Welcome to this webinar on vaccination as a condition of deployment. Absolutely delighted that so many of you have been able to join us. I think that's obviously a reflection of how topical a subject this is. And I see from the newspapers this morning that we now have an employment tribunal decision about the fairness of a dismissal when the employer in question had mandated vaccination in a care home, albeit prior to the mandatory legal requirement to do that. So that's this case of Allet versus Scarsdale Grange Nursing Home. It's on the government tribunal website. So the employer succeeded in defending the claim of unfair dismissal. In that case, it's a really interesting judgment, and it's well worth a read. Joining me this morning, really reflecting the nationwide kind of nature of the delegates on this webinar, we've got presenters drawn from our offices across the country. So Serbi from Cambridge, Joanna Burrows, Rebecca Pallett, Fiona and Helen. So thanks guys for joining me on this. In terms of today's agenda, I put there on the slide the topics that we're going to cover. So these really reflect the types of queries that we've been having. So which roles are in scope, the application of exemptions, evidencing vaccination status, how do you deal with redeployment, what about dismissal and the timing of notice, recruitment and new joiners, what do we do about contractual changes, and then really pleased that we've got Helen Tringham joining as a data protection specialist to look at some of the thorny data protection issues. Now, in terms of housekeeping, you may have heard that the webinar is being recorded. A copy of the slides and the recording is going to be emailed to you after the webinar. In terms of questions, please do just put the questions in the Q&A function. They'll only be visible to the presenters, and we're going to consider as many of those as we can at the end of the presentation section. So without further ado, I'm going to hand over to Serbi.
Thank you, Stuart. Good morning, everybody. I'll just wait. I don't know if Claire, you could just remove the obstruction on the slides, whatever that is. Thank you. Okay. Good morning, everybody. So just to give you a quick overview of the regulation. So on the 6th of January this year, as I'm sure you'll be familiar now, the government have amended the Health and Social Care Act regulations 2014, extending the scope of the mandatory vaccination requirements for staff beyond registered care homes to include the health and wider social care settings in England only. Accompanying the amended regulations has been guidance has been issued and FAQs by NHS England and Improvement, and this has been in two stages. Phase one guidance, which was issued before Christmas, deals with planning and preparation for the mandatory vaccination requirements, and phase two deals with the implementation of these requirements, and we'll look at that throughout the course of this session. Now, the principal legal requirement of the regulations are that a CQC registered person can only deploy or otherwise engage a person for the purposes of the provision of a CQC regulated activity if they provide evidence that they have been vaccinated or they are exempt from requiring vaccination. So if we can move to the next slide, what do we mean by being vaccinated? Well, this requires evidence of a complete course of a Medicines and Healthcare Products Regulatory Agency approved COVID-19 vaccination. Interestingly, the COVID-19 booster is not included as part of this requirement. And as if you didn't already know, these regulations come into force on the 1st of April this year. If you can go to the next slide, please. So just as a recap, examples, looking at what are CQC regulated activities, examples of the types of activities that the CQC regulate are listed in Schedule 1 of the Health and Social Care Act 2008. And at the end of the session, there'll be a slide which gives you a link to Schedule 1. But I have set out what the activities are on this and the next slide, which are also mirrored in phase 1 of the VACOD guidance, which deals with, as I've already said, planning and preparation. Children's services, community-based services for people with learning disability, substance misuse, hospices, health and justice secure settings are also types of services regulated by the CQC. The FAQs which accompany the guidance confirms that community pharmacy is not a CQC regulated activity. Moving on to the next slide, please. And the next one. Thank you. So as you can see on this slide, I have set out a roadmap of the key dates. The next key date for you guys is the 3rd of February 2022, being the last date for workers in scope of the regulations to get their first dose of an authorised vaccine, unless they are exempt from doing so, so that they can be fully vaccinated by the time that the regulations come into force on the 1st of April. And then the next significant key date is the 31st of March, by which time workers who are not exempt should be fully vaccinated in time for when the regulations come into force. Moving on to the next slide, looking at who is in scope of the regulations. Now, clearly, we all appreciate that this is a key hot topic for you guys at the moment. A key message in the phase 2 guidance is that the regulations will apply where a regulated activity is delivered by substantive, seconded or fixed term staff, bank and agency workers, contractors, volunteers, locums, honorary contract holders, students or trainees, or indeed any other type of worker involved in the provision of a CQC regulated activity, and who has direct face-to-face contact with patients or service users. The VACOD requirements include frontline workers as well as non-clinical workers, not directly involved in patient care, but who may have face-to-face contact with patients, including ancillary staff, so for example, porters, cleaners, or receptionists. The phase 1 guidance sets out 7 scenarios by way of examples to inform assessments around scope, and also a flowchart is included to assist on who is caught by the regulations. The guidance does not provide any further advice on determining potential roles that may be in or out of scope of the regulations, and this is being left for provider organisations to determine individually themselves. We understand that most organisations are taking a very inclusive approach to the interpretation of who is in scope, meaning that very few roles are being excluded from the VACOD requirements. One area which is giving rise to much debate is around whether third-party contractors should be vaccinated, and some trusts are taking a hardline approach and requiring all third-party contractors who are attending their premises to be vaccinated. Now, clearly, if you have an external contractor involved solely in delivering goods and nothing else, they will not be caught by the VACOD requirements. I, however, do think there is an argument that could be made that if any of the staff, the third party staff in question, are delivering items which facilitate the provision of a regulated activity by the registered provider, then they may be engaged in a non-clinical ancillary role of the type described in the phase 1 guidance. Another area of debate is around those staff who have contact with NHS patients as part of their health and social care provision for services that are not CQC regulated. Again, I think an argument could be made that if it is in the facilitation of a CQC regulated activity and there is direct face-to-face contact, they would be caught by the VACOD requirements. I'm now going to hand over to Jo, who's going to look at the application of exemptions.
Thanks, Debbie. Okay, so turning to the issue of who the regulations do not apply to, We know from the regulations and the phase 1 guidance that the applicable exemptions are very limited indeed, and staff will need to fall into one of these 5 categories. So the first is anyone who does not have direct face-to-face contact with people receiving care. Anyone under the age of 18 will be exempt. Those who have taken part or are currently taking part in a clinical trial for a COVID-19 vaccine are exempt. Anyone who is clinically exempt for medical reasons. And then finally, pregnant women who have the option to rely on the short-term medical exemption. In relation to clinical exemptions, we know that there are a very limited number of medical reasons which will attract a clinical exemption. And these are set out in the Green Book, but they include people who are receiving end-of-life care for whom vaccination is not in their best interests, people with learning disabilities, autism or other impairments, which means that having the vaccination could cause distress, and people who have had severe allergies to the vaccine or who have had a severe adverse reaction to their first dose. Next slide, please. In relation to women who are pregnant, the current guidance from the JCVI and the Royal Colleges is that vaccination is recommended for pregnant women, but there may be some pregnant women who have concerns about vaccination, and therefore there is this option of relying on the short-term medical exemption. For those pregnant women who choose to take up this option, the exemption will expire 16 weeks after giving birth, and this will allow them to be fully vaccinated during the periods of their maternity leave. So a registered person can continue to employ and engage individuals who have clinical exemptions or a short-term medical exemption. And we know from the phase 1 guidance that managers should undertake a risk assessment or to review and update existing risk assessments. And the purpose of this is to ascertain the potential risk of unvaccinated exempt staff spreading the virus, and to identify the level of risk of exposure to others in the workforce and to patients and visitors. The risk assessment should be kept under review and repeated as necessary, taking into account individuals' change in circumstances or in light of a change in national guidance. In terms of the risk assessment, managers may also need to consider implementing other measures or reasonable adjustments to help reduce the risks that have been identified. And as set out in the phase 1 guidance, this might include cleaning regimes, thinking about ensuring sufficiently ventilated workspaces, reviewing PPE equipment use, and undertaking regular lateral flow testing. These individuals should also be referred to occupational health as well, so they can provide advice and recommendations. And last week, the Faculty of Occupational Medicine issued some helpful guidance on what they see as being their role in the VCOB process. And there is a link to the Faculty of Occupational Medicine's advice at the end of the slides. Next slide, please. Thank you. So to ensure compliance with the regulations, a registered person will need to obtain evidence from individuals as to their vaccination or their exemption status, and also have processes in place to document the status and ensure ongoing monitoring. So we've set out on the slide there the recognised evidence that you should accept of vaccination or exemption status. And Helen's going to kindly talk about the data protection issues that arise from that later. In relation to pregnant women, they can use the MAT B1 certificate. For those who have been involved in a clinical trial, they will need to obtain a letter from the organiser of the clinical trial, and they can then rely on that as proof of their exemption. And finally, in relation to clinical exemptions, just a reminder that there is a formal medical exemption process that individuals need to go through. Medical exemption status can only be authorised by a GP or a specialist clinician. And occupational health have made it very clear that they are not in scope for giving advice on medical exemptions. Staff will need to apply via the NHS COVID Pass or by ringing 119. They will be sent an application form that they complete and then send on to the GP or specialist clinician. And then a letter will then be sent to the individual confirming whether or not they have medical exemption status. And just finally, that there isn't a right of appeal against that decision. Going to hand over now to Becky to talk about redeployment.
Thank you, Jo. Thank you. So you've got staff who are refusing to be vaccinated or who aren't vaccinated yet, and you obviously then need to look at redeployment. So I'm going to look at the process that you'll need to follow for that redeployment. So the phase 2 guidance sets out a framework that we've been waiting for some time. It says that the approach generally needs to be fair and transparent, and that it must be conducted in an equitable fashion. So what does that mean from a practical perspective? The guidance does warn against employers just extending their existing policies on redeployment to what is obviously a unique situation, and the framework does contain some elements that perhaps wouldn't be found within your normal redeployment processes. So the first step, which the phase 2 guidance requires, is for employers to look at whether roles can be reconfigured to remove patient-facing elements from those staff who are not vaccinated. We did invite questions prior to the session, and one of those questions was about the extent to which you're required to make adjustments to an existing role, and whether it's sufficient to say that adjustment would not comply with the expectations of the service, whether it's sufficient simply to say that. The straightforward answer to that question is no. You need to follow a process of considering whether the adjustment is possible, and what impact it might have on other staff and patients. So if it's going to put a burden on, a significant burden on other staff to pick up those duties, then that might be a reason for refusing it. The guidance does say in bold letters, patient pathways, care and experience must not be compromised. So there's certainly an option to refuse to reconfigure a role on that basis, or because it would impact too much on other staff. So once you've considered reconfiguration, you're then required to look at redeployment opportunities in an attempt to minimise the loss of staff from the NHS, and that search for an alternative role is you're obliged to continue that search during any notice period up until the individual's last day of employment. It's worth noting that it isn't a redundancy process that we're going through, so it's not a case of looking for suitable alternative employment. We're looking for alternative roles as a means of avoiding dismissal, and if they don't accept that new role, then they'll be dismissed, and Stuart will look at that shortly. So the guidance recommends that you meet with staff to explain the situation and explore potential adjustments to the existing role, and then what redeployment opportunities are available. It says that you ought to pause external recruitment for non-patient facing roles until such time as the redeployment process for those who are not vaccinated is completed. There'll certainly be a need for communication between trusts and across ICSs about what the opportunities for redeployment are and what's available in the wider health economy. From an employment law perspective, I think that will need some thought if people are going elsewhere, and I suppose it would either be a case of seconding somebody into a different organisation, or their employment terminating with their current employer and simply being offered a new role that they take up with a different employer. A lot of the questions that we had prior to the session were in relation to the sort of competing priorities of different types of staff, including those with protected characteristics. And within the pool of staff that are to be redeployed, I think there's likely to be those with different protected characteristics and different needs. And so a question might arise as to who takes priority. For those, and it's worth saying that I think the guidance isn't 100% clear on this issue, and it will probably kind of come out in the wash. But the conclusion that we've come to, I think, is that staff who are already in a redeployment process for other reasons, so already in an organisational change process, in respect of them, you shouldn't pause that existing process. You should continue with it in the normal way, and they shouldn't be disadvantaged by the sort of introduction of the non-vaccinated staff. So those existing processes ought to continue, but then unvaccinated staff should be given priority in respect of new vacancies which are not patient facing, and in respect of those vacancies, they shouldn't be opened up to the wider pool of staff awaiting redeployment until it's established that no unvaccinated member of staff is appointable to that role. But it's worth saying, and the guidance is very clear about this, that priority doesn't apply, so that the unvaccinated staff don't get that priority in respect of new non-patient facing roles over disabled staff who might require adjustments, staff who are pregnant or returning from mat leave, or those who are entitled to be slotted into a role under a contractual organisational change policy. So in the normal way, you'll need to consider what reasonable adjustments might need to be made for people with disabilities, and that, as you know, may well mean giving them a role as an adjustment. You'll also need to put pregnant women or those returning from mat leave sort of at the front of the queue in respect of suitable alternative employment or alternative roles. And it might also mean that unvaccinated members of staff miss out on a vacancy because somebody who's already in another redeployment process or otherwise has a legal right to be slotted in takes that vacancy. So then in terms of the sort of nitty-gritty of the approach that the guidance recommends, the redeployment framework that had been anticipated is actually in fact incorporated within the phase 2 guidance, and I'm not going to take you through the sort of minor details of that because it is set out really quite clearly. But in essence, the first thing that you should do is identify the opportunities and who's in scope, and then you should set your selection framework. You'll already have a redeployment process in place which will include making vacancies available to staff and providing lists of roles and so on, and it seems sensible that process should be extended to the unvaccinated staff. Because there are likely to be quite significant numbers of staff being redeployed for in respect of not having a vaccine, you will need to have competitive processes for some roles. Although it's worth noting that actually the guidance does say that that unvaccinated staff could be slotted in where it's considered appropriate to do so. And then the approach requires that staff should be supported through the process by their manager, and I'm going to talk a little bit on the next slide about that support process, because there are some fairly significant there are some specific rather than significant specific measures that the guidance requires you to take. It's worth noting that there is also an obligation on the employee. There are also obligations that require them to be proactive, to engage in the process, but also quite interestingly to produce a CV or a recruitment profile, setting out their knowledge and skills and so on, which will then help you in the search for redeployment for them. So in terms of the timing of the redeployment process, I think Fiona, have you changed the slide? Sorry, I can't see. Yes, thank you. So in terms of the timing of the redeployment process, for those who are not vaccinated, conversations about redeployment should start immediately if they haven't already, and I'm sure that they have. any newly configured roles or any redeployment that's being taken up should start from the 1st of April 2022, unless you've agreed, you've reached a mutual agreement with the member of staff that it should start earlier, in which case that's a matter of contract and it starts earlier. Staff who are redeployed because of a lack of vaccine are generally not entitled to pay protection if they go into a lower band role or have different working arrangements in their new role. But if they're temporarily redeployed due to not being vaccinated for, and this is interesting, for a good reason, then they may be entitled to pay protection. So I think there is some discretion to offer it if somebody is temporarily redeployed, but you will need to be careful about how you apply that discretion, and it must be applied consistently if you want to avoid discrimination claims. And I think there'll need to be a discussion and kind of identification of what constitutes a good reason. And then finally, I'm just going to touch on as I said, the support during the redeployment process. So there is a requirement that staff are supported through the redeployment process by their manager, and there are specific obligations actually on line managers. So they must undertake one-to-one conversations, signpost staff to information, and request occupational health input if it's required. But then in addition to those sort of general requirements, there are actually certain specific measures that the guidance says that employers ought to offer. Excuse me, and I've put those 3 things on the slide there. So access to support services such as interview skills workshops, signposting to psychological health and wellbeing services, and reasonable paid time off to attend interviews. Now, initially, I kind of thought, well, that might be to attend interviews within the wider health economy, roles at different organisations, so that we're not losing staff from the NHS. But in fact, there isn't any such caveat in the guidance. So it seems to me that as drafted at the moment, it means that whatever role they're going for, whether it's outside the health economy or otherwise, then they ought to be allowed that time off. So I'm now going to hand over to Stuart to talk about formal action and dismissal.
Thanks, Rebecca. So, well, as Rebecca said there, ultimately, as we all know, employers are going to have to consider the dismissal of staff whose roles are in scope of the regulations and who refuse to be vaccinated in line with the mandated timescales, excluding those who are exempt, or they decline to disclose their vaccination status. And that's a fairly unique and novel set of circumstances. And notwithstanding really that unique and novel set of circumstances, employers obviously shouldn't lose sight of or overlook the employment law basics. And we've got to put those basics on the slide there. You need a fair reason to dismiss someone. You need to act reasonably and follow a fair process in dismissing anyone. And you need to give appropriate notice of termination. So none of those things should be kind of lost in managing this novel process. Moving to the next slide, in terms of the reason for dismissal, the phase 2 guidance says any dismissal will be on the grounds of contravention of a statutory restriction, i.e. the regulations. So that's a reference to section 98(2)(d) of the Employment Rights Act, which makes it clear that it's a potentially fair reason for an employer to dismiss an employee if the employee could not continue to work in the position they held without contravention by the employee or the employer of a duty or restriction imposed by or under an enactment. But later on in the phase 2 guidance, it says, as previously detailed, the fair reason for dismissal will be on the grounds of a contravention of statutory restriction, or in the alternative, some of a substantial reason. Some of a substantial reason could apply where, for example, an individual refuses to confirm their vaccination status and it cannot be established from existing records. It also seems to me that some of a substantial reason might potentially be argued as an alternative fallback fair reason to statutory restriction if for example, an employee argues successfully that their role shouldn't have actually been in scope, such that their continued employment wouldn't have contravened a statutory restriction, and that's because a dismissal that's based on a genuine and reasonable, albeit mistaken, belief that continued employment would have been in breach could potentially be for some of a substantial reason. So that's worth bearing in mind. The slide just makes clear then, as Rebecca's just said, the dismissal won't be for redundancy, and the guidance is very clear on that. In terms of what a fair process looks like, as we've said, it's not enough to have a fair reason. An employer needs to act reasonably in treating that reason as a sufficient reason to dismiss the employee, and that means following a fair process. So the phase 2 guidance refers to a formal review process with unvaccinated staff or staff whose status can't be ascertained. And that review process needs to clearly explain the consequences of remaining unvaccinated, clarify the dates by which the requirements have to be complied with, set out what steps will be taken for those who remain unvaccinated by those dates, and explore alternative options such as role adjustments or redeployment. And then following that formal review process, the phase 2 guidance says that there should be formal meetings from the 4th of February with those staff who remain unvaccinated, and that staff should be notified that a potential outcome of those meetings may be dismissal. What the guidance says about those formal meetings is the chair of the meeting should assess whether adequate consideration of alternatives, such as adjustment or redeployment, has been given, and whether, in the light of those matters, employment should be terminated. So what that means, that fair process, it means that any representations made by the employee need to be properly taken into account. And the guidance also says that if an employee is dismissed following that formal meeting, employees should be provided with a right of appeal. Clearly, an employer going through this formal process, this fair process, needs to properly document it. They need to properly document that the process has been undertaken so that the employer is in a position to defend its position and any action that's been taken as a consequence of that formal process. In terms of notices of dismissal, on the next slide, any dismissals will obviously need to be on appropriate notice, and whether that's statutory notice or contractual notice. And in terms of the timing of that notice, the guidance is very clear that notice shouldn't be given before the 4th of February, and it shouldn't expire before the 31st of March. And what that may mean is that there's a period of time after the 1st of April for employees who have a longer period of notice that kind of takes them past the 1st of April. And in terms of managing that notice period, I've listed some potential options there on the slide, in particular for those employees whose notice does extend beyond the 1st of April. And what the guidance says for those employees is, where individuals are serving a notice period which extends beyond the 1st of April, they will need to be redeployed or removed from patient-facing roles whilst they await termination of employment. If redeployment is not available, individuals should be placed on leave from the 1st of April until termination takes effect. And then it goes on to say that payment in lieu of notice can only be applied in accordance with contractual arrangements or written particulars of employment. So if you don't have pay in lieu of notice clauses in your contract, you won't you won't be able to pay in lieu of notice. Just a final point around notice periods. The guidance is clear that employers can issue staff with notice of dismissal whilst they continue to explore redeployment options, and that notice periods and the search for alternative roles can run concurrently. And then just returning to my point there about employers having to act reasonably and follow a fair process, that means that employers should continue to explore redeployment and alternative roles throughout and up to the very end of the notice period. I just want to look at some potential legal challenges to all of this in terms of that individuals might say. I mean, I've set out some of those potential challenges on the slide. I'm not going to pretend that they're an exhaustive list of challenges. There's a whole range of reasons why people might challenge them. So people may say that no fair reason has been established. They may say that no fair process has been followed. They may say that their role isn't properly in scope, so any dismissal of them based on their being in scope it isn't fair. And that goes back to my point that I made earlier about a genuine belief that the roles in scope might amount to some of the substantial reason. The employee may say there's been insufficient attempts to adjust their role or to redeploy them. They might say that the redeployment process that Rebecca's talked about has been carried out unfairly. They may comply, albeit during their notice period, and then say that if you continue to dismiss me in those circumstances, that would be unfair. And then people may allege discrimination. And I think it might very well be that a number of people do. I think my view on that is, provided the process is carried out in a kind of fair and non-discriminatory manner, I don't think that claims of direct or indirect discrimination should succeed. But a whole myriad range of reasons why people might bring potential challenges. I just want to finish on the issue of collective consultation. So this has been a sort of subject of a bit of debate. And is there an obligation on employers in these circumstances to collectively consult? The guidance says no. It says that NHS EI and DHSC don't believe that any dismissals arising in these circumstances mean that the collective redundancy obligations are engaged, but it's the decision for each organisation. That said, I mean, employers will want to engage and work in collaboration with their staff side representatives around the formal measures that are being taken and the redeployment process and potential dismissals. And the guidance kind of encourages that collective collaboration with staff side. If employers do that, it's going to be of assistance in any event if some sort of Section 188 challenge is made. Just before I hand over to Fiona, the questions are kind of piling in. As I said, we'll deal with those at the end of this presentation section. So over to Fiona now.
Thank you, Stuart. We've looked at pausing external recruitment in order to maximise redeployment opportunities, but you are still going to need to recruit for roles which aren't suitable for mandatory vaccination redeployment, patient-facing roles predominantly, and where there isn't a suitable candidate for redeployment within the pool. New joiners, of course, benefit from a grace period under the regulations, which means that if they start between now and the 1st of April, but have only received one dose of an approved vaccine, they've actually got a further 10 weeks from the date of that dose to provide evidence that they've received a second dose. Or indeed, if they start from the 1st of April onwards, they must have had one dose of a vaccine at least 21 days before they start, but they then again have 10 weeks from the date of that first dose in order to provide evidence that they've received their second dose. This grace period is to help balance the requirements of the policy with workforce pressures in health and care services, but it might just seem like a bit of a drop in the ocean. Going forward, it's really beneficial to ensure that you can rely not only on the legislation to require new recruits to be vaccinated or exempt, but to ensure that this is also a contractual requirement for new starters as well. Indeed, in the Phase 1 guidance, NHS England specifically recommends the provision, a provision about vaccination and clinical exemption into recruitment processes, offer letters and contracts for new starters. Our view is that if a role is going to be subject to the regulations, this should be made very clear from the outset of engagement with candidates. And it's helpful to specify in all relevant job adverts that the role is subject to the requirement to be vaccinated or exempt, and that successful candidates will need to evidence their vaccination or exemption status. Care does need to be taken to make it clear that those who are exempt won't be excluded, and it's helpful to mention where applicants can get further information about the requirements and how they might apply to them. It's important to remember that at recruitment stage, you shouldn't ask questions about an applicant's vaccination status or require them to evidence their vaccination or exemption status until an offer of employment is made. Now, this is because Section 60 of the Equality Act prevents employers from asking prohibited health questions. This prohibition is designed to ensure that disabled applicants are assessed objectively for their ability to do the job in question and that they are not rejected because of their disability. But asking a candidate about their vaccination status could be a prohibited health question. Now, that said, Section 60 does provide exemptions to the prohibition on asking health questions before an offer is made. The relevant exemptions here apply where either one, the question relates to a function that is intrinsic to the job, or two, where a reasonable adjustment may be needed for the candidate to carry out the job. The NHS England guidance provides that it will be lawful to ask candidates about their vaccination or exemption status when recruiting staff and workers whose roles are likely to involve CQC regulated activities and face-to-face contact with patients or service users. Our view is that this is intended to apply from the 1st of April, when vaccination will be a legal requirement for the role. In terms of your contracts themselves, we would suggest including provisions that certain roles are subject to the requirement to be vaccinated or exempt. In broad terms, we'd suggest covering the following: that the individual must provide evidence of vaccination or exemption status on an ongoing basis, that they must inform you as their employer if they cease to be appropriately vaccinated. That would apply in circumstances where the requirements are extended to cover things like booster vaccinations, because obviously at the moment we're very clear that the regulations only apply to the first and second dose of a vaccine. But we were trying to make sure that any clauses that are inserted into contracts are future-proofed. Making clear that you as the employer have the right to terminate the contract if their vaccination or exemption status is not provided, and also making clear that the provision of false information will be treated as a disciplinary offence. As part of the preparation stage of the guidance, NHS organisations were urged to work in partnership with staff representatives to draft vaccination policies, setting out the approach that will be taken to mandatory vaccination, and to provide some key categories of information, including how vaccination status can be evidenced, how vaccination or exemption status data will be processed, and Helen's going to be talking about that in a bit more detail shortly, how any formal policies will apply to staff who can't comply with the requirement, how vaccination requirements apply to new recruits and agency staff, and finally any equality issues that arise from complying with the regulations. Now, in our experience, it's still the case that many NHS organisations haven't implemented these policies yet, and I think the reason for that is that there's been so much focus on preparing all of the various stages that we've covered during the course of this session. It's been waylaid during the course of those other tasks, but it will really help to ensure consistency over the coming weeks if you do have a clear policy in place, and it will help to demonstrate that you've taken a fair and reasonable approach and that you've acted in line with the guidance, and it will help to protect you against some of those risks that Stuart outlined on the previous couple of slides. I'm going to hand over to Helen now, who's going to discuss data protection issues.
Thanks very much. You'll all be very pleased to know that the new regulations specifically state that the data protection legislation must still be complied with. So to be very clear, the new regulations do not trump the data protection regime. Before we move on to the detail of the data protection law, I wanted to explain why we need to consider the data protection aspect of this. As I'm sure you'll all know, the data protection regime applies to the processing of any personal data, and essentially processing means to use personal data in any way. In this context, employers will be processing personal data when they collect any evidence from an employee about their vaccination status, including doing digital checks, when they collect any evidence from an alternative source about the vaccination status of their employees, if they record that evidence on their system, and if they then store that evidence on their system. Each of these activities, so collecting it, recording it, storing it, will be a separate processing activity. And as we'll see later, you'll need to identify a lawful basis for each of these activities to make the processing fair and lawful. In addition, vaccination status is special category personal data and therefore needs to be treated more carefully than regular personal data. So in summary, if you collect and record any evidence of employees' vaccination status, you will be processing personal data, and therefore you need to comply with the UK GDPR in relation to each processing activity. So moving on to the detail of the data protection law, all employers as data controllers must comply with the 6 data protection principles listed in Article 5 of the UK GDPR. The most relevant for our purposes are lawfulness, fairness and transparency, which we'll explore in more detail in the next slides. The next principle is purpose limitation, whereby personal data should only be collected for specified, explicit and legitimate purposes, and not further processed in a manner that is incompatible with those purposes. You must be clear about what your purpose is for processing vaccination status data from the very start, i.e. from the moment you collect it. The next principle is data minimization, which means that vaccination status data must be limited to what is necessary. So you'll need to consider how much evidence to collect and be able to justify the amount that you require. And finally, storage limitation mean that vaccination status personal data must not be kept for longer than you need it. Looking at the first principle in more detail, data must be processed lawfully, fairly, and in a transparent manner. For the processing to be lawful, you'll need to identify a lawful basis for processing under Article 6 of the GDPR. And because vaccination status is special category personal data, you'll also need to identify a condition for processing under Article 9. For the processing to be fair, you need to ensure that you've considered how the processing of vaccination personal data may affect your employees, and that you only handle employees' personal data in a way that they would reasonably expect you to. For the processing to be transparent, you'll need to provide a privacy notice to employees, which should ideally be done at the point personal data about vaccination status is collected. That privacy notice has to outline, amongst other things, the purpose of the processing, the legal basis for the processing, and the recipients of the personal data. You should therefore consider what information was given to employees at the point at which their vaccination personal data was collected about how their vaccination personal data would be used, in particular, who would be accessing it. If you're not the entity that collected the vaccination status personal data from the employee, or you're not satisfied that they were given the correct information, at the point at which that personal data hits your systems, you should ensure that employees are told how their personal data will be used prior to undertaking the further processing. If you can't do this, there's a real risk in a breach of the UK GDPR and the Data Protection Act 2018. The main question to consider is whether the employees are aware that their personal data is being used in the ways that you propose to use it. As set out on the last slide, for each processing activity undertaken in relation to vaccination personal data, you'll need to identify a lawful basis for that processing. This means, for example, that you'll need to identify a lawful basis for collecting it, a lawful basis for recording it, and a lawful basis to continue to store it. The Information Commissioner, who regulates data protection legislation, says that for public authorities carrying out their function, public tasks may be an applicable lawful basis. For other public or private organisations, legitimate interest is most likely to be appropriate, but you need to make your own assessment for your organisation. As it's now a legal requirement under the new regulations for you to check people's COVID status, you may be able to rely on legal obligation as your basis for processing. In August 2021, the Secretary of State for Health issued notices under the Health Service Control of Patient Information Regulations 2002, often referred to as the COPE notices. These notices require organisations providing health services to process confidential patient information for COVID-19 purposes. The notices themselves give examples of COVID-19 purposes, including controlling and preventing the spread of COVID-19. Although the COPE regulations are distinct from the data protection legislation, they're likely to cover the sharing of vaccination information by NHS organisations to another NHS organisation. And that's in circumstances where it would not usually be allowed to access such patient information. But that's only the case if that is necessary to achieve the COVID-19 purposes. The legal obligation imposed by the COPE notices could also be a relevant factor when identifying the lawful basis for processing personal data, particularly in relation to legal obligation. However, it's really important to note that the notices do not remove the requirement to comply with the data protection legislation. They do contain limitations and safeguards on how information may be processed, and they're scheduled to expire on the 31st of March 2022. Therefore, if you wish to rely on these notices to justify your lawful basis for accessing vaccination personal data, you need to be mindful of the limitations of relying on them. So moving on, as vaccination status is special category personal data, in addition to the Article 6 lawful basis that we've just looked at, you'll also need to identify a condition for processing under Article 9. The conditions listed on this slide are those that we think are most likely to be engaged by the processing of vaccination information, and that is that the processing is necessary for carrying out obligations or rights of the employer in connection with employment, that the processing is necessary for the purposes of management of health or social care systems, that the processing is necessary for reasons of public interest in areas of public health. However, they can only be relied upon if you also satisfy specific criteria in the Data Protection Act 2018. For example, it's likely that you'll need an appropriate policy document in place which details how you'll comply with the data protection principles I mentioned at the outset, and explains your position in relation to the retention and erasure of such personal data. The COPE notices described earlier are relevant to the conditions for processing under Article 9, particularly the management of health or social care systems. So moving on to our key recommendations, this is a really complex area, and we recommend that you seek advice from your data protection officer or advisors in relation to any of these data protection issues. It's really, really important to get it right, as we're seeing an increase of claims from people asserting a breach of their data protection rights, combined with any employment claim that they may threaten. Our key recommendations are to record the reasons for processing the vaccination status of employees. Remember, your reason for recording your employee's vaccination status must be clear and necessary. An employer would need to be able to clearly justify any records it keeps or information it retains. Only collect the minimum amount of data required to achieve the purpose identified. You should ensure that the employee's vaccination status is kept confidential and only disclosed in defined circumstances. You should also consider who should have access to it. You should ensure that personal data is only kept for as long as is required and no longer. The Information Commissioner advises that employers should regularly review whether they still have grounds for the collection and retention of vaccination data. Be clear to the employees about why you're collecting information about their vaccination status and how it will be handled. You should be clear in relation to what you intend to do with their personal data, and do not use it in ways people would not reasonably expect. You should consider updating your privacy notice to reflect this, and whether to update your data protection policies and procedures and your record of processing activity. Where the use of vaccination data is likely to result in a high risk to individuals, such as a denial of employment opportunity, or if you're processing health data on a large scale, you should complete a data privacy impact assessment. The DPIA will assist in working through whether the employer needs to collect the information and in demonstrating what the grounds are for processing the special category personal data. Back to you, Stuart.
Thanks, Helen. So Helen talked there about the next steps for organisations around data protection. I've summarised on the slide there next steps for organisations, kind of more generally, just pulling together the various strands of the presentation this morning. So continue to hold one-to-one conversations with staff to address barriers and vaccination hesitancy. Continue engagement with staff side, the Freedom to Speak Up Guardian and Staff Equality, Diversity and Inclusion networks. Continue to record vaccination status of workers in scope, taking account of what Helen said. Consider your organisation's redeployment opportunities, and then consider the termination process. So that's a kind of checklist of everything you need to have in mind. We've obviously referenced various resources as we've gone through the session this morning. We've listed, I think, those on the next slide, just so you've got the kind of links when you receive the slides in one place. So that's a kind of handy guide to the key resources that you should bear in mind. So we'll turn to questions now. We've had a lot of questions coming through on the QEA. I've seen colleagues have been busy answering some of those where they can as we've gone through. Some of those questions talked about this. So what's the case that I mentioned at the beginning of the session? This is, in actual fact, it's the first case I've seen around mandatory vaccination in the context of COVID. And it's I'll spell the case to you. So it's Allett, A-L-L-E-T-T-E versus Scarsdale Grange Nursing Home. And if you search in Google for, or other search engines are available, if you search for gov.uk employment tribunal decisions and put Allett in, it will pull it up. And as I say, it really is quite an interesting decision in this sphere. In terms of some of the questions that we've had around dismissal, there's a few quick ones that I can just kind of pick off before I hand over to colleagues. So does all of this kind of fall outside maintaining high professional standards? Yes, so this won't, maintaining high professional standards won't be engaged by this. When can notice be served? So notice can be served on or after the 4th of February. Is the notice statutory or contractual? Well, it's contractual, but if a statutory notice period is greater, then you obviously need to give the statutory notice period. We've also had a question, well, a number of questions around the interaction between long-term sickness absence and the regulations. So, Serbi, if it's okay with you, I'll read the question out to you, and then if you can do your best. So the question is, where staff have indicated that they don't intend to be vaccinated, then go off sick, citing the regulations as the reason for the sickness absence, how do you advise that this is managed? Phase 1 of the guidance advises that people on long-term absence from work, including sickness, would not be in scope unless and until they return to having any face-to-face contact. Are they managed in line with sickness, or are they managed in line with VCOD? So over to you, Serbi.
Thanks, Stuart. This is a really thorny issue, and it's quite a live issue and a tricky issue. So where you've got a member of staff who's on long-term sick leave, then clearly guidance, the phase 1 guidance states that they are exempt from the VACOD requirements. But where you have a situation where you've got a member of staff who is refusing to be vaccinated, and it's clear that they are refusing to be vaccinated, then the phase 1 guidance makes it clear that you should be having or engaging with them and having conversations with them, and these should be conducted in a sensitive way, compassionate way, to understand why it is that they are not choosing to be vaccinated. And I know a lot of you are going to be thinking, well, they're off sick, they don't want to engage with us. Just because they are off sick does not mean that they cannot continue to have a dialogue with you about why it is that they are off sick and what you can do to address the concerns that they have. What the phase 1 guidance states clearly, it's important to ensure that where someone is unvaccinated, that they are treated with dignity and respect, and that you should be working with them as managers towards compliance with the VACOD requirements, but being mindful of, you know, whether there are cultural, religious, philosophical reasons why they are choosing not to be vaccinated. If you get to a situation where ultimately they are just saying, look, I'm sorry, I'm just not going to get vaccinated, well, clearly this is going to be in breach of the VACOD requirements. And as Stuart has said, this could potentially amount as a dismissal for some other substantial reason. Clearly, I know you don't want to go down that route, but before you get there, I think it's worth you taking the steps to engage with this member of staff, trying to understand why it is that they don't want to be vaccinated, getting them to a position where they agree to be vaccinated, but ultimately if they point blank refuse to be vaccinated, then I think you're going to have to think about dismissing the individual or termination of their employment, unless you can redeploy them, obviously. If you do end up dismissing someone in those circumstances, you've got to be live to the issue that if they are off with some health-related reasons, then they may potentially be able to bring discrimination claims. But I think ultimately you may be able to justify provide objective justification for the reason for terminating their employment in those circumstances. I don't know. Is there anything more that you want me to add to that? Anyone else?
Thanks for that, Toby. We also had a number of questions about vaccinations from abroad, Joe, and I wonder if you could kind of deal with some of those. So this was the very first question we had, in fact, which is why I picked it. So if someone within scope has had one of the vaccines that's not authorised in the UK and is not happy to have the UK course, what are the options? Any comments around that?
Yeah, thanks, Stuart. So I think in the first instance, you need to explore with the individual why they're not happy to have their top-up single dose of a UK authorised vaccine. And then I think if they're still going to refuse, the options are rather limited, I'm afraid. The individual could try to apply for a medical exemption, but I think it's very unlikely, given the limited criteria that apply to clinical exemptions, that that's going to fall within that. So I think you're left with the only other option is then to continue to manage them in the same way as others who are unvaccinated, but in scope. I can't see anything else in the guidance which provides any other information on that question. So that would be my advice. Thanks,
Joe. Rebecca, I think this next one's for you in relation to redeployment. So we've got two here on redeployment. How do we manage those who fall in scope of these regulations who have a disability, but their reason for not having the vaccination isn't related to their disability? Do they get preferential access to vacancies above someone who falls in the scope of the regulations but doesn't have a disability?
Okay, so I think the normal rules on reasonable adjustments apply to the unvaccinated staff. So you're only under an obligation to make an adjustment or make a reasonable adjustment if that adjustment is going to alleviate the disadvantage that the individual is put at by virtue of their disability. So if they're not having the vaccine for a reason unconnected with their disability, then your obligation to make those adjustments doesn't arise. In that case, there's no requirement, I think, to make a reasonable adjustment, and no reason why they should be given preferential treatment.
Thank you. There's another one on redeployment, while you're unmuted.
Okay.
Whilst we understand that we should consider the enhanced statutory rights those who are currently being redeployed outside of the VCOD process in relation to disability, pregnancy, maternity, redundancy, that this guidance in respect of VCOD states that due regard should be given to the impact of decisions on those people with one or more protected characteristic. So this goes right around to that kind of hierarchy of redeployment that you talked about in your session.
Exactly. So I think, as I said when I was talking about that, there are elements of the guidance that don't necessarily fit together perfectly, and I think this is one of those areas, but the process, as I said, that we would advise is that those staff who are already within a redeployment process or an organisational change process, you continue with them as normal, and the unvaccinated staff don't get any kind of preferential treatment or priority in those processes. And then for new non-patient facing roles that arise, that's where unvaccinated staff do get the priority. So they shouldn't go out to internal or external advert or be published on any list until such time as you're satisfied that an individual who isn't, or that it's not possible to appoint an unvaccinated member of staff. But as I said, it's that, and this is one thing that the question identifies, that priority in respect of those new non-patient facing roles doesn't trump the rights of disabled staff, pregnant staff, or those who would otherwise be contractually or legally entitled to a role. So I think it may be that that's what the guidance is talking about when it's talking about the impact of decisions on people with protected characteristics. It may also be talking about looking at various protected characteristics within the group of unvaccinated staff. And there, I think if you stick to your usual processes in terms of adjustments and so on, and you're conducting a fair process, then I think you probably won't go too far wrong.
Thank you. Look at this. Joe, there's one here about people who test positive for COVID. So are you happy to take that one?
Yeah, I think I've seen quite a few queries on this, and yeah, really interesting question, and another one of those thorny issues, because unfortunately the guidance here doesn't really seem to fit together. So this is a scenario where individuals have said they're going to have their first dose, but they unfortunately test positive for COVID, which means that they can't then meet the 3rd of February deadline. So the guidance goes some way to answer this question. In the frequently asked questions document that came out with the phase 2 guidance, there's some commentary at question 20, and it talks about how individuals will have a temporary medical exemption on medical grounds, and this will exempt them from being required to have the first dose by the 3rd of February. The temporary medical exemption will start from the date of their positive test, and they will then have 42 days to receive their first vaccination. So that's giving them the 28 days during which they can't have the vaccination, and then 14 days to go off and book a vaccination and have their dose. This is where the guidance then becomes a little muddled, because the guidance then goes on to say that after the 42-day period, those individuals will no longer have a temporary medical exemption they can rely on. And that creates some difficulty, because we know that those individuals will still have to go off and have their second vaccination. We know that on medical grounds, they will have to wait 8 weeks between the first and second dose. So it seems to me that these individuals can continue to rely on a temporary medical exemption, which will then cover them up until the 10-week period they have to go off and have their second vaccination. And this is analogous to the situation with new starters, because we know from the regulations that new starters can start in their roles, and they will have a 10-week grace period within which to have their second vaccination. So in my mind, I'm struggling to see why you would treat these staff less favourably than those new joiners. So our advice would be that these individuals can continue to rely on that temporary medical exemption.
Okay, thank you. Joe, Fiona, a question here around repayment of MAT pay under Agenda for Change. So the question is, if an employee who's notified her employer of her intention to return fails to do so, potentially because they don't want to be vaccinated, within 15 months of the beginning of their maternity leave, she's liable under Agenda to Change to refund the whole of her maternity pay. So the question is, can organisations recoup, and potentially should they recoup?
Yeah, thanks, Stuart. It's another thorny question, and they just keep coming, don't they? Strictly speaking, under Agenda for Change, that money would be repayable, so that the occupational maternity pay that the employee would have received would be repayable if they decide not to return to work for any reason. That said, it's probably going to come down to a trust by trust local decision, because NHS organisations can decide to exercise their discretion whether or not to recoup that money. By way of example, some trusts don't recoup occupational maternity pay in situations where somebody who's been on maternity leave hasn't returned to work because they've been made redundant. So that's not something that wasn't related to their decision not to return to their employment. So I think it's going to come down to probably a case-by-case basis and exploring precisely what the reasons are for the decision not to return to work, and then making sure that if you do exercise your discretion not to recoup the money in those circumstances, that you do so in a fair and reasonable way.
Okay, thanks, Jen. Interesting ones, questions, a few questions around TUPE, which I'll deal with because I feel bad just dishing out the questions to everyone else. So the kind of general scenario on the questions is you've got an organisation with a service which is going to transfer that service to another organisation. Organisation one has taken a particular view around employees, some or all of them, and whether they're in scope of the regulations, and they've determined that they're not. They go to organisation B under TUPE, and organisation B says, well, we think they are in scope. What should happen in those circumstances? I think everyone seems happy that I've said I'll deal with this. So I think there, obviously, organisation 2, the transferee, they can't be dismissed prior to the transfer, because the transferor can't rely on the transferee's reason for dismissal. So it seems to me they have to go over under TUPE, and then the transferee, the new organisation receiving them, needs to follow a fair process in connection with managing the situation. And that might mean that those people are employed for a period of time and aren't able to be deployed to CQC regulated activity. So an interesting one there. And then another one, which I'm happy to pick up again in relation to dismissals, is we've already started a process, a redundancy process in respect of an unvaccinated employee. Do we need to continue with that process, or can we kind of switch to the VCOD process? And my view there is I think you should continue with the redundancy process. So if the employee is genuinely redundant and you followed a fair process in respect of that redundancy, it might mean that you can kind of complete that process sooner than you'd complete the VCOD process. In any event, switching to the kind of VCOD process now, I think is risky. It's almost akin to the circumstances where an employer starts a redundancy process, then says, oh, actually, I've got a mobility clause, so it isn't a redundancy process. And the tribunals kind of generally frown on that. And I think you'd almost certainly face an argument from an employee that that you're using or relying on the VCOD reason when the real reason is a redundancy reason. So there's some dismissal questions. So there's a few questions coming in around scope and the scenarios that are given in the phase 1 guidance around what does incidental mean, a finance manager in a corridor, that type of thing. Do you want to say just a few words about what that kind of incidental contact point and the examples that are given in Appendix 3? Is that okay? Yeah,
thank you, Stuart. Yes, there's been quite a few questions around. I think one of the questions was, I work in a corporate team and I'm away from having direct face-to-face contact with patient service users, but a nurse comes to the corporate section of the trust. And my answer to that would be, as long as that corporate wing is entirely separate from the main area of where a CQC regulated activity is being undertaken, and there is going to be no direct face-to-face contact with a patient or service user, then they would not be caught by the VACOD requirements. Where you have got an individual who is a member of staff who's walking through a corridor where you know, a corridor in a hospital where CQC related activity is taking place, but they themselves don't have any direct contact, usually in their undertaking of their role, with patients or service users, but they do need to use that corridor to access other areas of the hospital where there may be patients or service users using that same corridor, then I would say that you would be caught by the VACOD requirements. Yeah, does that cover them all?
I think so. That I'm just having
I think
a quick,
that was the two I saw. I don't know if there was any other. I'll have a quick look and jump in again if there is any others.
There's a question here, Helen, just so you don't escape completely, if that's all right. There's something here around how long would the documentation relating to dismissals need to be kept? We currently keep our records for 2 years, so that kind of retention point, I don't know if you're able to say anything about the data protection principles around that.
Yeah, absolutely. So you're able to hold on to documentation as long as you can justify the need to hold on to it for. So in that particular circumstance, I'm sure one of my colleagues will let me know how long an employment claim might be brought after, but after that period of time has expired, then it seems natural to hold on to it for not much longer than that.
Okay, thank you. Flicking through, these are still quite a few. Question here from, can you reiterate the grace period for new starters between their first and second dose? I think, Jo, you dealt with that.
It was me actually, Stuart. I was literally just typing a response to that question.
Oh, right.
It's absolutely fine. So it's 10 weeks from the grace period is 10 weeks between the first and the second dose. And actually there's an appendix right at the end of the phase 1 guidance which sets that out. So if that's something that's relevant, it's probably worth having a little look at that.
Okay, any questions that others can see that they can pick up? I'm just flicking through.
Yeah, there's a question, Stuart, around, well, there's quite a few questions around maternity leave and what evidence the pregnant woman needs to provide. So in relation to the MAT B1 form, if those are issued late, so I think somebody had said they may not be issued until around 20 weeks, then that member of staff should apply for a formal medical exemption in the normal way, and the application would be reviewed by a midwife, and then they would receive a letter confirming that they've got medical exemption status.
Okay, and there's a question here around, is there any tension between the approach that the CQC are suggesting that they'll take to enforcement and the approach being taken by some organisations around the extent of scope, and potentially arguing everyone's in scope potentially? And I suppose that this comes back to the point that I made in my session around what's the fair reason for dismissal, because if an employee could genuinely succeed in showing that they're not within scope, their continued employment wouldn't be a contravention of a statutory enactment, so the fair reason wouldn't be established. But if the trust was able to show on reasonable grounds that it genuinely believed that there would be a contravention of a statutory enactment, I think the trust is going to be able to rely on SOSR. But that's one of the kind of battlegrounds that I identified in terms of legal challenges to people going through the dismissal process.
If I can just,
sorry. No, go ahead.
So is it related to what Stuart was saying? If so, just carry on, Becky.
No, I was going to start a different set of questions, so you go ahead.
I was just going to say, there was a question around whether there was any additional guidance on what constitutes incidental contact. Unfortunately, there isn't. Basically, I just think we're going to have to take a common sense approach on that. And would passing through a patient area fall in scope? Yes, because there is going to clearly be incidental contact. The whole purpose of these requirements are to reduce contact with people who have got COVID. So that it's about health and safety and protecting service users and patients. So if you think of it in that way, is there going to be any kind of contact, whether it's direct or incidental or, ad hoc, then yes, they would fall in scope.
I was just going to say there's a couple of questions about sort of indirect discrimination claims, I think. So there's one about trusts. In our case, Black and ethnic minority staff are significantly overrepresented in the unvaccinated cohort, despite our best efforts. Where does that leave us? So that would be an indirect disability discrimination claim in the same way. And somebody else asked a question about staff who refuse to be vaccinated for, or it's a philosophical belief. Perhaps the court might hold that it's a philosophical belief that somebody holds against vaccination. So, I mean, in terms of indirect discrimination claims, you've always got the opportunity to objectively justify those your actions. So whether that be dismissal or redeployment, on the basis that it's a legitimate. Sorry, wrong way around, a proportionate means of achieving a legitimate aim. And I think in circumstances where there is a legal requirement that you don't deploy people to patient-facing roles or to patient contact where they're not vaccinated, undoubtedly that, along with the need to protect staff and patients, would provide you with that objective justification.
Okay, and then this might be a joint one for Serbi and Rebecca. So what do you do with an employee who says, well, the pandemic means I've been working at home for 2 years. I don't see anyone other than my kind of dog, because I never, I'm at home all the time. How can you say my role's in scope, and what should you do with that person? Or can you not adjust my role to put me into a home working situation? So maybe if Serbi does the first scenario and Rebecca, you do that second one about adjustment to the role, is that okay? Serbi?
Yeah, I mean, if you look at the reason why people have been working from home, it's in furtherance of guidance that has been issued by government in controlling the whole pandemic. So that's why we've been working from home. And if that guidance changes, as we have seen recently, as of yesterday, that it's changed and we are now being allowed to go back into the workplace, they're not going to be able to rely on that as a reason for continuing to work from home. And employers are now going to be looking at bringing staff back, where possible, back into the work environment, unless obviously there are clinical reasons or other reasons, health related reasons, or so forth, that they should continue to work from home. So, and if it is the case that then there is no valid reason why they should continue to work from home and they need to come back into the work environment, then they will be in scope. And this is where, do I hand over to Becky to talk about redeployment?
Yeah, so I mean, before you get to redeployment, there's an obligation to look at whether a role can be reconfigured, and in this case where somebody's been working from home, it might well be that it's possible to formalise that working arrangement so that their role is reconfigured so they don't have contact with patients and so on, that would bring them in scope. So certainly that would be the first process you'd need to go through, would be looking at formally reconfiguring that role to avoid them being in scope. Yeah.
Thank you. And the questions coming here. Please do you know when the contract will end if they're not willing to take the dose? I have a staff member who does not want to take the vaccination and has asked if their contract will end on the 3rd of February or the 31st of March. The position there is kind of clear that that person doesn't or wouldn't need to be dismissed until the 1st of April, so they would be able to remain in employment. I'm just looking at any more questions that people have. There's a question here Fiona, to you around contractual changes. So could we kind of elaborate on the changes that we suggest should be made to contracts of employment?
Yeah, of course, Stuart. So we would suggest making it clear that the role is one to which the regulations apply, that staff will be required to provide evidence of their compliance. And because at this stage we don't know whether or not there might be any extension to the requirement for vaccination, for example, it could be extended to cover boosters, we'd suggest putting wording in that seeks to cover that as well. We'd also want to make it quite clear that if the information that had been provided by an employee was found to be false about their vaccination or exemption status, we've got that would be treated as a disciplinary offence.
Okay, so that would be for kind of existing employees and as well as putting those in the contracts for new employees. Is that?
I think it would probably just be for new employees, Stuart, given that we'll have gone through all of this process and we should know the status of our existing employees having gone through this by the 1st of April. But certainly for any new staff that you're taking on from now, provisions in the contract offer letter and warning them of the requirements at recruitment stage is helpful.
Okay.
Do you want me to pick up the one about using DBS criteria?
Yeah, very happy for you to pick up the one for the DBS criteria.
Sorry, that's okay. So someone's posted a question about what about using DBS criteria for determining whether someone is in scope or not. So what I would say is obviously that the purpose of the DBS checks are that you are going to have contact with service users and patients, and I think it's perfectly valid to use that as a rationale for saying that people who are going to be DBS checked, then those roles are going to require having contact with patients or service users, and therefore would be in scope of the regulations unless they can be exempt for any other reasons.
Okay. Helen, I think I found a data protection question for you in the things. If the agreed people in the organisation access, or the agreed person in the organisation accesses the national vaccination record for staff to determine vaccination status, can they then compile a list for team managers of who they know are unvaccinated and share it with them?
Yeah, I think the key point here is why the team managers need to know the vaccination status of employees. If you're able to justify a good reason as to why they need to know it, then you're likely to be able to find a way through the data protection legislation to do so. But my main concern around that is ensuring that the data is kept secure and confidential, and the way in which you give them that information. Clearly, if you send it on an email, there's a risk of it being sent to the wrong person, or there's a risk of someone accessing it in the future that shouldn't have access to it, which increases the risk of a more delicate data breach. So to answer, you need to be able to justify it and make sure you keep the data very secure. Stuart, I saw a couple of other data protection queries. Do you want me to answer those?
Yes, please.
One was about the copy notice or the copy notices and whether or not they'll be extended. I think they've already been extended once. And what I've seen in the NHS FAQs is that they should be reviewed before the 31st of March, and they may be extended after that date. But at the moment, we simply don't know. And the third question I saw was in relation to accessing central databases to gather the vaccination status of employees, and surely that's an easier way to do it. I think it is a way to do it, but my concern about that is the information that was given to the employee at the point at which they were vaccinated, because I think it's perhaps unlikely that they were told that an employment decision would be made about them at the point at which they were vaccinated. So if you're going to access central databases, it's really important to make sure that your employees know how you'll be using their personal data at the point at which it hits your system, in order to perfect anything that perhaps wasn't done in the correct way at the outset. So I would say it is a way to do it, but you need to proceed with caution.
Thank you. Well, we've come to the end of the allotted time. I think that the volume of questions just shows how hot a topic this is. at Mills Reeve will obviously continue to produce information and updates in relation to this. If you do have any queries, please do feel free to contact any of us. We'd be delighted to help. Thank you very much for attending this morning. Thanks for your participation. Thanks to my colleagues for joining me on this, and have a very good rest of the day. Thanks very much.